Hello everybody. I am Barbara Schofield. I'm nurse consultant for older people up there in West Yorkshire. Another Yorkshire accent to listen to, I'm afraid, from Calderdale and Huddersfield. I lead on dementia and delirium in the organisation, and I'm going to talk to you about POD. I don't know if anybody in this room has been involved in the POD research. Yeah, I talk a little bit about it. This is not about the research, but I always acknowledge the research because POD came out of the research. I'm working with young people, young A-level students who come in and support our older people in hospital. So just a little bit of background. Calderdale and Huddersfield Foundation Trust is 2 district general hospitals still. I don't know how long they will survive. We're starting to shift services across site a little and seeing some movement, but nobody's been courageous enough yet to actually build a hot site and a cold site, but I can see it's probably coming, and I'm guessing it's happening all over the country, yeah? That we're not hanging on to clusters of district general hospitals. And we have some community services. In Calderdale, we own the community services. In Huddersfield, it's a social enterprise. So it's quite complex working across the boundaries and working with our partners. And the next few bullet points you will be familiar with. We, as everybody else, is facing a growing number of people admitted to hospital with or developing delirium. We've got issues recognising those at risk. Still some issues in diagnosing the condition. And our staff are under pressure, and in particular the nurses. Danny and I have been saying they're on the knees. Yeah, they're on the knees. It's really, really difficult. And we've already heard this morning that at least 25% of our hospital beds will be occupied by people with dementia, many of whom will develop some impaired deterioration in the cognition at least, if not a full-blown delirium. And probably another 25% of people who are admitted with undiagnosed dementia or delirium or will develop delirium. So we're going to have lots of our hospital beds occupied with people with delirium. And we know that potentially it can be prevented in some people and reversed or at least managed very well. Back in 2012, we were approached by a research team and invited to participate in a delirium project, a research project. The ward that was chosen at the time was Ward 19, was then an acute trauma orthopaedic ward, and soon to become the fracture neck and femur ward. So it was a perfect ward to start off with. And as kind of the preempt to the research study, I did some audits on the ward. And that was about observing all members of staff at different times of day, doing all kinds of different activities and observing the patient's reaction to them. But I didn't really need an audit to see this. It was chaos. I don't know if anybody had ever been to Huddersfield Royal Infirmary's Ward 19. They openly say that you walked on the ward, you felt chaos. It's a big, long, straight ward, a 12-bedded area at one side, a 12-bedded area at the other side, and side rooms and all sorts of activity in between. We got patients walking around the ward, falling, lots of different incidents happening on the ward. People were confused, agitated, lots and lots of one-to-one supervision. Possibly, we know now on reflection, a lot of it wasn't necessary. People were either isolated in side rooms or isolated and bored, stuck at the bedside, if not in bed. Yeah, even as recently as 2012. And many people being discharged to care homes prematurely, if not inappropriately. For staff, we've got low morale, we've got high levels of stress and turnover, lots of sickness and absence, lots of complaints, and care was just uncoordinated. It was chaos, and that's how I saw it. And at that point. It felt like, is this the right place to introduce this research? But we did, we went along with it and we introduced the research. So this is just an acknowledgement for those of you who don't know. The research was to test the feasibility and acceptability of a multi-component system of care to prevent delirium in the hospital setting. It was modelled on the Hospital Elder Life programme and NICE guidance. And it was a research team that were out of the University of Leeds and based in the Bradford Institute for Health Research. Should put my glasses on really. And basically this was what POD was all about. The patient group that we were looking at and the patient group that we looked at for the pathway, although it doesn't exclude people under 65, were people aged 65 and over, as NICE guidance, with either cognitive impairment and or dementia, current hip fracture or severe illness. And severe illness was a bit ambiguous. What's severe illness? Who can define what severe illness is? Well, we chose and still choose to define it as a person who is admitted to hospital and within 72 hours, so not by 72 hours, continues to deteriorate or shows no improvement and is significantly ill enough to be admitted to hospital. Does that sound reasonable? It's very difficult to find a definition for severe illness. And those are the 10 clinical factors that I'm sure you'll all be familiar with in terms of prevention and managing patients with delirium. And what POD offered was kind of 3 steps or approaches to care. The first was for the clinical team to sort out, so that was managing those 10 clinical factors. So putting a care plan in place that actually helped all the clinical staff to do that. The second component was that there may be some interactions within those 10 clinical factors that needed a slightly higher level of input, so from some of the specialist teams in the hospital, or a slightly lower in terms of clinical input level of skill. And this was the component that really came from the Hospital Elder Life programme, where they'd been really successful in the appointment of volunteers in supporting older people in the hospital setting. And the third component, where the volunteers really come into their own, is this notion of social engagement, meaningful occupation, actually engaging with people socially in a hospital setting. And Danny mentioned this morning about people kind of shock horror. No, don't encourage people to stay. We don't want people to stay in hospital longer. We want them to go home. And if you engage with them, they'll stay in hospital longer. And I think we all probably know in here that's just not the case. So those are the 3 components of POD. I have to say, and I'll hold my hand up and say that when we were participating in the research, we weren't very good at it. And in particular, the volunteer component. We were recruiting volunteers through the standard hospital process. And people would come and appear to be enthusiastic, and they didn't come back. They'd come for a couple of weeks. They didn't really get it. They weren't committed. They didn't have the right skills. And then along came 2 wonderful young people, and I did intend to put the photos up. I will send them to Graham so they can come out. Hannah came along first, shortly followed a couple of weeks later by Jacob. And these 2 young people were A-level students at separate colleges, but they were amazing, very, very different. And Danny and Graham have met both of them. Hannah wanted to be a neurosurgeon, and she was very, very outgoing, extrovert, very sociable kind of person, lots of ideas buzzing around in her head. And Jacob was 6'5", I think, shy, but very, very pleasant, lovely young man. And together they didn't half make a team. and they just got it. There is no other way of saying it. They understood what POD was meant to be about. And over a very short period of time, working with us, they convinced me, who then had to convince other people, that we could engage with A-level college students for 2 years, picking them up in the first year, bringing them into our hospital settings to work with older people. And they shaped the model. They really shaped that model. And we quickly developed an agreement with one of our largest local colleges that it would become something called enrichment. Are people familiar with A-level enrichment projects? Yeah, for those of you who are not, it's a formal process whereby people, the young students have placements of varying length, and they can take one for 2 years, and POD is a 2-year placement, and it's formally evaluated, it's reported on, and it contributes towards their portfolio for university. Now, this particular college, we do engage with other colleges, but this particular college attracts a lot of wannabe medics, nurses, therapists. So it was really important to these young people to make this happen, to come, to be committed, to come. So we kind of had a hit there. I mean, Hannah and Jacob convinced us of this. They'll come, they'll continue to come, because they need it. It will develop a portfolio that will get them into medical school. Well, I thought, well, that's a bit ambitious, because it's very difficult to get into medical school. But what we are seeing is that the young people who are coming in are doing just that. They come in and they're staying and they're committed. Initially, they come for them. They soon are hooked. What we ask of them is that they just commit to once a week, a 2 to 3 hour placement, anything between 7 in the morning and 7 at night, and just, to come any day of the week. And we managed last year, Hannah and Jacob was kind of like 3 years ago now. The first year we managed to recruit 28. Last year we had 68 young people coming in to 6 hospital wards. So we managed to get a 7-day cover. Some of them now have gone on to university. And this year we're just in the middle of interviewing again, and we're looking at about 60, 64 again this year. I have to say that I've put a few points up there about training and support, and this requirement of coordination. It doesn't come without its problems. It's really time consuming. We rigorously interview, kind of screen them, we train them, and we offer quite intensive support and supervision at the beginning when they first come in. But it really works. Older people, as I think somebody else talked about it this morning, this intergenerational, this kind of older person, younger person dynamic, the older people absolutely love the young people coming in and working with them. But there is a time commitment to it. And we hit the first blip after the first year, because when I first started introducing this project, I'm a nurse consultant for older people. I cover everything, not just delirium and dementia. I work 3 days a week because I have university commitments 2 days a week. When I first introduced this, I had a senior sister who was on secondment working with me on the dementia and delirium pathway, and I had a full-time senior occupational therapist. He left and wasn't replaced, and then they pulled Mary, my Mary, I called her, back into a matron post. So there was just me, and it was really difficult. I had to think on my feet, what do I do? How do I make this work? And again, Hannah and Jacob came up with the answer. They were now second years, approaching a time to go to university. They said, we'll do it. We'll lead it. I'll lead it on this hospital block, and Jacob will lead it on that hospital block, and we'll do it. And we'll keep in touch with you, so you don't have to keep in touch with any one of them. and we will be at least on the end of a phone for people. And it really worked. And right up to the night before Jacob came to Birmingham to study medicine, he was on the ward supporting students that were just coming in. So that was a model to follow. The following year, we did the same. They'd already identified the leads for the next year, and I had this little list of people that could do the same. And at this point, we were starting to get more interest, so we opened it up on more wards. Last year, one of the lads who hadn't been a student with us had applied to study medicine, hadn't got in, and approached me and said, I'm taking a gap year. I want this on my portfolio. So he was available like 5 days a week, and he took up a lead last year. And we're doing the same again this year. It still makes it hard, but the students not only develop skills in working with older people, in working with doctors, in working with nurses, learning all the jargon and getting coached for interviews and all kinds of things, but they're developing skills in leadership as well. So it's been massively important for them. So this is, Hannah and Jacob chose Scooby-Doo when we first presented this down in London. What do? They do anything, as little or as much as they're able and want to do. And I think the first time that certainly Danny met Jacob, he was this very shy, retiring young man standing and talking to a room full of people about it. And he touched the heart of everybody because he said, sometimes it's just about sitting and holding their hand. And sometimes it is. But sometimes Hannah was building life stories with people, wasn't she? Working with families, with a gentleman with quite advanced dementia. So they do as little or as much, but the little is much appreciated. And the much is about how far they want to take it, really. They do work with My Life, and we just recently, it's not on there, but just recently we've had the Alzheimer's Society approach us, and they're going to come in and do some work with the students, coaching them to offer them a little bit more support and a bit of a broader kind of skill set in terms of working with people with dementia. So whatever the patient wants, really, is what they do. Something else that, and I apologise that this is a superwoman, but they are only women at the moment. But something else we also developed on those 2 trauma orthopaedic wards was shaped on the role of the volunteers. We introduced a role called the social engagement and care support workers. And the people who applied for these were people who've been healthcare assistants or worked with people with dementia in the community setting. And we developed these roles because we weren't able to recruit nurses. And we were finding it difficult to fill all the nursing posts and all the healthcare assistant posts. And we saw the value of the volunteers and felt that there might be some value in testing out some permanent roles that actually do what the volunteers do and more, and support the volunteers, but free up the nurses and the healthcare assistants to actually manage the patients that are their priority at that moment, while the social engagement workers are working with the people who might otherwise have distracted them. And that's exactly how it's working. And now the nurses and the healthcare assistants will report that they have more time to go into the day room and join in the activities. And typically what they do is they engage in group work in the morning, and then they engage in one-to-one work with the people who can't get to the day room in the afternoon, doing all those kind of things, really. And they are developing something that's a bit like More About Me. They're developing a patient carer journal in partnership with the carers that is like a log of activities of what the person's been doing during the day. And sometimes it's, can you fetch the pyjamas in, or whatever, or I can't find Albert's pyjamas, where are they? Sometimes it is a two-way communication tool, but mostly it's about the activities of the person during the day. So just very briefly, this is our care philosophy. We've been talking about recognising risk, and we too have a rapid risk assessment tool that helps us to make sure we get the mental capacity right, that we're recognising people who do still want one-to-one supervision. On this ward, it's very rare that happens now. We have This Is Me type memory care plan. We do use My Life, and we call it My Life. Are we still allowed?
Yes.
Okay. And then we participate. Oh, Thingy, I love Thingy.
Maybe we'll call it that.
And these are just some demonstrable results, really. This is an interesting one. This is one-to-one supervision, which the support workers were introduced earlier this year and after January. So in April, the two that we had were both on leave. And one-to-one supervision went up. And gradually we've seen a decrease, and there hasn't been any one-to-one supervision needed on either of the wards throughout October. So it's really, really been fantastic. Falls. Sue asked me about the colour coding of this. Basically, I think this is pretty standard, but green is non-harm falls, yellow is little harm fall, amber is significant harm fall, and red is death by fall. So this is where we were 2013, 2014 on one of the wards. This is a fractured neck and femur ward, after it became a fractured neck and femur ward. So very variable. Where you see the kind of the peaks is often the same patient. I think, Danny, you said that this morning. Where have the significant harm falls have gone? And this is to July this year, and significant harm falls have gone again. Now, it could appear that our lesser harm falls and the no harm falls have actually risen in terms of looking at the numbers. But this year, we've been reporting all non-harm falls. Whereas in previous years, it didn't look as if we had many. I think that was the tip of the iceberg. We weren't reporting them. Some got reported, but we weren't reporting them routinely. This year we are. So it looks like it's more, but it's going to be significantly less. And we know it is. It just feels like that out there on the ward. And that's me and Pod. Any questions?